Acute coronary syndromes are called acute coronary syndromes because we can't really tell them apart unless the patient gets an ECG. The patient's symptoms in acute coronary syndrome are very similar. You can't really tell them. It's difficult to tell them apart based simply on clinical presentation. There are three acute coronary syndromes. We have unstable angina. Next, we have non-STEMI or non-ST elevation MI. And then finally, we have ST elevation MI. So this is still a perfusion concept. What are the three elements of perfusion again? What are they? Mr. Khan?
Oxygen.
Okay, so the first one is the heart or the pump. What are the other two?
Lungs.
What was it? I can't hear you.
Lungs.
Not really. Yeah, blood vessels and blood volume. So these three interact to give you perfusion. The heart, the pump must be working effectively through competent blood vessels, namely the arteries and the veins. The arteries specifically must be able to dilate and contract in response to body's needs, and there must be adequate blood volume in order to supply the entire body. So in chapter 38, the problem here is in the vessels affecting specifically or supplying specifically in the pump. So this is now chapter 38 is on coronary blood vessels. Now remember that the heart needs blood supply too. It's not just going to supply the entire body systems, but it has to supply itself. It's very selfless in the sense that it prioritizes other organs before itself. The number one proof there is when do the coronary arteries perfuse? When do they receive blood supply? Do they perfuse during systole or diastole?
Systole?
Imagine it this way. So this is your heart. Okay, so we have 4 chambers. And during systole, which is left ventricular contraction, blood goes this way. There is forward flow. Now the coronary sinuses, there are 3 main ones, arise out of the base of the aorta. So since blood is going this way during systole, there's no way blood can enter the 3 main vessels, namely the left anterior descending artery, the right coronary, and then the one in the posterior artery, coronary artery. So they only therefore receive blood during diastole. When the left ventricle stops beating, blood falls back on the aorta and then filling the 3 main coronary arteries. So if we do a cross section, this is the posterior, this is anterior, So there are three main. One is here, one is here, and then another one here. There's also, because this is the right side, and this is the left. The three main arteries are, coronary arteries are your LAD, RCA, and I keep forgetting what the lateral one is. Anyway, so they fill during diastole only. They cannot fill during systole because, again, of the forward flow of the blood. Regardless of the artery affected, the main cause here is, of course, atherosclerosis. So if you compare this to chapter 36, when you discuss atherosclerosis in third semester, this is the only difference here is that the vessel affected is now the coronary artery. But this is the same risk factor shared by people who have a stroke, who have hypertension, who have peripheral artery disease. This one is simply referring to, this one just happens to be affecting the coronary arteries now. As the plaque develops, let me just go to the picture and I'll go back to CSA. If you look here, so this is your normal vessel. Once plaque starts to build up, caused by these factors here, namely hypertension, smoking, high cholesterol, which is the main thing responsible for depositing these cheesy substances in between the intima and the medial layers of the vessel. Again, I'd like to emphasize that the plaque isn't on top of the endothelial layer. It's not on the intima, but between the intima and the medial layer. The harder surface is, of course, the intima layer, because that is the one subjected to high pressures in the artery pumped by the heart, sorry. So they must be able to withstand all that pressure, okay, 365 days a year, 60 to 100 times a minute of the heart beating. So that blood, the pressure against the arterial walls are withstood by your intima as long as they remain intact and they remain strong. However, the plaque deposits here, which is a combination of these substances here, including also calcium. There will be calcium deposits there as well. All of those will serve to weaken the wall eventually. And then once you have a ruptured endothelial surface like this one right here, where this one is enlarged, so the intima layer eventually breaks. Now, a damaged epithelium, especially in the coronary artery, is very likely to attract blood clots. And it's just a matter of time. So if you look at it here, once the plaque is big enough, so this one, let's say, is already 80% clogged. 80% of the lumen is open, so you have 20% clogged. So once this ruptures, though, even though you still have 80% that's able to perfuse the myocardium, once a clot forms like this one here, so you have a blood clot that forms, it can form within minutes, and without any intervention, either dissolving that clot or putting in a stent, can result in permanent damage, irreversible damage to the myocardium. So let's go to chronic stable angina. So as long as the patient has adequate blood flow, even though it's already 20% or maybe up to 50% blocked, as long as there is still blood flow to the myocardium, the patient will go on, life as usual. However, during instances wherein blood's blood supply or oxygen supply is decreased, for instance, the only way that will happen is if you increase demand. Now, during instances of increased oxygen demand, such as exertion, for instance, no matter what you are doing, whether it's running up the stairs, whether you're shoveling snow, whether you are um, experiencing a severe emotional sensation, or you experience a very stressful event, all of these conditions increase oxygen demand. It's during these episodes that the patient's heart, or particularly the affected coronary artery, is unable to supply that increased demand. So this leads to pain, which is ischemia. Now, if you remember in stage 2 of peripheral artery disease, that was what happened. That was what caused the intermittent claudication in peripheral artery disease. So as the patient walked, there was pain on the legs, and then the patient stopped walking, the pain was relieved, if you remember that. So in chronic stable angina, the same thing. This one just didn't affect the peripheral artery though. This one affects the coronary artery. So same thing, you are shoveling snow, you're doing a strenuous activity. So you increase oxygen demand, in which the atherosclerotic coronary artery is already partially blocked, so therefore it is unable to supply the increased oxygen demand, causing ischemia, which is manifested as chest pain. Again, because you stop, naturally that will stop your activity. So the patient experiencing chest pain will drop the shovel, probably sit down and take a rest, and then the chest pain goes away because now you restored blood flow, you were able to meet oxygen demand once again. As long as the plaque remains stable, the patient will continue to have chronic stable angina. So this one will not lead to permanent damage. As that plaque though advances, if it now reaches up to, let's say, 90% um, obstruction of one or more coronary arteries, now that is now called acute coronary syndrome. So the first of the three is unstable angina. Here is your definition. Thank you for reading, Mr. Espinosa.
Unstable angina is chest pain or discomfort that occurs at rest or with exertion and causes severe activity limitation. An increase in the number of attacks and in the intensity of the pressure indicates unstable angina. The pressure may last longer than 15 minutes or may be poorly relieved by rest or nitroglycerin. Unstable angina describes a variety of disorders, including new onset angina, variant Prinzmetal's angina, and pre-infarction angina.
Okay, thank you, sir. So this is equivalent to, in the peripheral artery disease, this would now be stage 3 because the pain, the chest pain in this instance, is now occurring even at rest, meaning there is not necessarily any increased oxygen demand. You're just sitting on the couch, for instance, and the chest pain just comes on. So this now indicates unstable angina. We will not be testing between new onset, variant, or pre-infarction angina. Unstable angina is the same regardless of the type, because they all appear unprovoked, meaning there is no activity, and unlike chronic stable angina, which still responds to nitroglycerin or rest, the unstable angina no longer responds to nitroglycerin or rest. And unlike chronic stable angina, wherein there's always a triggering factor, meaning there is a cause, there is an identifiable cause, and you can see a pattern. It is reproducible, just like stage 2 PAD. There's none in unstable angina. The patient in unstable angina gets the pain in no particular pattern at all, meaning you cannot predict it. In chronic stable angina, at least you know when the chest pain will occur, because you remembered, oh, the last time I shoveled snow, I had chest pain. So the patient either takes nitroglycerin with them or can preemptively take nitroglycerin sublingually before they engage in the um, physical activity. As stated here, the most serious of the acute coronary syndrome is, of course, an MI. There are two MIs. We have N-STEMI, or non-ST elevation, and then we have ST elevation MI. In non-STEMI, in both instances, there is 100% obstruction in the of one or more coronary arteries. So there is now a zone of injury here, meaning some of the, if you think about it, it's kind of like this. If you have, let's say this is the a myocardial cell, okay? Or let's say this is the ventricle, rather. So let's say this is the left ventricle. So there are since the coronary arteries always are located on the outside, so the first tissues that it will, of course, supply are coming from the outer and then going from the inner. So therefore, if it is blocked, so let's say this is a coronary artery which is blocked, this is the only thing left open. Okay, so this is your atherosclerotic plaque, leaving you with just this much open, supplying blood to the myocardium. So you have this tiny opening here. All right. So if you imagine that occurring here, so this tissue from here to here will still have blood supply, of course decreased. So therefore the innermost or the most distal part of the myocardium is the one closest to the endocardium. Right? So therefore the zone of injury will occur here first. This will be your zone of injury. So the furthest tissue, just like your legs, for instance. So if you have a PAD affecting your femoral artery, for instance, it will be your lower legs and your feet that will have the injury first, correct? So it is always the distal area. So it works like this also in acute coronary syndromes. However, as long as that plaque, for instance, or the lack of blood supply, the ischemia is restored, so let's say the patient takes nitroglycerin, for instance, and then it dilates the artery there and then or stops the activity, or receives a thrombolytic, for instance, because they reach the hospital soon. So there will be no permanent damage because you restored. There is no zone of necrosis. So when we say infarction now, infarction is actual death of the tissue. When something dies, can you resurrect that? No, I only heard of Jesus coming back to life, but I've never seen anything else once dead come back to life, right? So if as long as we keep it from getting to a zone of necrosis, meaning as long as we intervene then it will just stay as a zone of injury. Injury, there is ischemia there is injury, but the cells recover, okay, but not once you suffer an actual infarction. So that what happens in non-STEMI. In non-STEMI, there is no ST elevation. What you will see though is an ST depression in and STEMI. We'll discuss the waves and complexes in next week in chapter 34, but I'll just give you a quick rundown for today. All right, so let's say one heartbeat, which is an S1, S2, is represented by P wave, Q, R, S, T wave. So this P is called the atrial depolarization, or this is atrial contraction. The QRS is ventricular depolarization. And then finally, the T wave is ventricular repolarization. This is just a quick rundown. I'll repeat this again next week. Now, that means for these are all electrical activity. So this is the on a EKG sheet. So EKG paper has vertical lines and horizontal lines. The vertical line is voltage, whereas the horizontal line here, this is time in seconds. So you can see there, if the vertical axis here represented by the waves are representing voltage, that meaning this will represent the amount of electrical activity within the heart, within each heart cell. So you can imagine the strength of the or the amount of electrical activity happening in the ventricles during contraction, because they dwarf the electrical activity in the atria. So if P is your atrial contraction and this is the electrical activity, this is probably only 1 millimeter high, and you can see the difference between atria and the ventricles. So there's so much electrical activity, especially when the ventricles contract. And even when it's not contracting, T wave is repolarization, meaning the ventricles here are starting to get more positively charged again. If you remember this from A and P, so between repolarization, so let's say this is a resting cell. So a resting cell which has just depolarized is more negatively charged. As it starts to repolarize, now the cells are now becoming more and more positive. They are getting ready for the next heartbeat, the next ventricular contraction. So the third, of course, is once it's all positively charged, then that cell has to release all that energy in there, resulting in depolarization. So this is your resting cell, repolarizing cell, and then this one is a about to depolarize cell, okay, about to discharge all that energy, resulting in ventricular contraction. So in the ST segment here, between right after a ventricular contraction, from when it's just discharge all this energy right here to before it starts to repolarize. This is now your resting cell. So there should be no electrical activity during that period. We're talking about very small fractions of a second, by the way, here. This is not, because imagine if your heart beats 60 to 100 times a minute, meaning all these things are occurring in less than a second. For instance, the QRS complex is about 0.1 seconds only, the actual ventricular contraction. So it's so fast. All of these events here are occurring very fast. So because imagine if you have a minimum of 60 beats a minute, that means the heart has to complete all this within 1 second before it can do the next heartbeat. Meaning it has to, the atria has to contract, pass the blood to the ventricles, and then the ventricles has to get rid of that blood to the lungs and to the aorta, and then repolarize before the next heartbeat, all finished within less than a second. The patient even has less time the higher your heartbeat goes. So for instance, you can only imagine how much of these events have to occur if your heart rate is, let's say, 120 when you are jogging, for instance, or you're going for a brisk walk, for instance. Okay, so all these events have to occur in such, or in even shorter time. Okay. So in non-STEMI, because there is now ischemia to the myocardium. So let's talk about the, let's say, the ventricle. So if the ventricle doesn't receive blood supply, it becomes very irritable, and therefore the ST segment is no longer isoelectric or flat. It will now be, let's say, this is your so the ST segment is now going to be depressed like this, meaning it's unable to repolarize because it didn't receive any or enough oxygen. So therefore, will you expect the next contraction to be normal if it experienced ST depression, or let's say it wasn't able to repolarize correctly? Meaning, I mean, there's still a T wave, but then will there be a perfect heartbeat, ventricular contraction specifically on the next heartbeat?
No.
No, not unless it is able to. Plus, remember that the ST segment is the only time that the heart is able to rest. Okay, so let's say that's even less than 0.1 seconds. So that's the only time that the ventricle is able to rest. So in this instance, if it is depressed now and it cannot literally, it cannot rest, how long before this heart will start to fail if it's not afforded any rest? Okay, not long. Right. So this is now, of course, this one though indicates that the patient's heart suffered ischemia. It was deprived of oxygen. However, the only thing, the only bright side to it was the oxygen supply was restored, but it didn't erase the fact though that it was exposed to ischemia.
Professor.
Yes.
So this all happens during the systolic pressure time, or like?
No. If you look at it here, so systole is really this part right here. This is systole when the QRS occurs. This is now diastole. And then this is early systole. Early systole, this is main systole, and then this one is diastole.
Okay, thank you.
So there are a few things because again, the three acute coronary syndromes is not easy to tell apart. When a patient comes in with chest pain, you're not sure if this is unstable angina, if this is non-ST elevation MI, or if this is ST elevation MI. We need a few tests in order to tell them apart. So as stated here, can somebody read this, please? Thank you, Ms. Harisha. Sahida.
Yes. Patients presenting with NSTEMI typically have ST and T wave changes on a 12 lead ECG. This indicates myocardial ischemia. Initially, troponin may be normal, but it elevates over the next 3 to 12 hours.
Okay. So regardless of whether or not the patient's chest pain is caused by non-STEMI or STEMI, the patient will have some troponins released. The troponin, though, doesn't initially rise until about 2 hours after the injury, after the ischemic episode occurred. So you won't see troponin until at least 2 hours. However, what makes troponin very useful is it peaks around 48 hours. So the highest level would be, if it's a true STEMI, it peaks around 48 hours and then it remains elevated until about 10 days. You'll see the no, it's too far. Anyway, so the troponins, we have two troponins. We have troponins T, troponins I. They are the very sensitive indicators because they are the ones that are earliest to be released by the injured heart muscle. So they cross from the myocardium and then enter the bloodstream. Okay, so these are enzymes released by any injured myocardial tissue. So making them very specific to acute coronary syndromes. We can still use CKMB, if you remember that from A&P. CKMB is still cardiac specific. However, they start to drop about 24 hours after the MI, meaning they will only be present for a short time. Another useful part of the CKMB is because we can have another infarct after one infarct, meaning after one heart attack, the patient may suffer another one because most atherosclerosis is not confined to one coronary artery. So maybe you're just lucky today that you had one of them completely blocked. So you may have another one in the hours or days that come later. So that part makes CKMB as the reliable determinant in order to see, did the patient suffer another MI, rather than just saying, oh, this is the same MI, because they could be 2 or 3 separate MI episodes. Any question on that part? Because the troponin, again, peaks around 48 hours. So let's say you had one heart attack today. The troponin will start rising within 2 hours, and it starts it keeps rising, and until the level stops, it peaks around 48 hours, about 2 days after the infarction. And then at that point, it starts to gradually drop. Now, the drop in the troponin is so slow, it's not excreted that fast by the kidneys, plus the injured myocardium doesn't stop releasing it after the initial part of the injury, meaning the injured, or the infarct rather, the dead heart tissues do not stop releasing the troponin until about 7 to 10 days later. So it will remain elevated. So if the patient suffers another heart attack in between, it can't be seen in the troponin level anymore. So that would make your CKMB the other determinant. So the CKMB will also be monitored to see if it, after it drops, it peaks and drops. If it peaks and drops another day, then that means the patient suffered another MI in between. Does that make sense?
Yes, Professor. What is
Yes.
Okay. Whereas a STEMI, so an non-STEMI, usually you have ST depression, not ST elevation, hence the name non-STEMI. In a STEMI, you have ST elevation. And it may be paired with T-wave inversion as well, as you can see the changes right here. So this is your T-wave inversion. This is ST elevation. So remember, the ST segment is supposed to be flat or isoelectric. So this one is elevated, indicating a lot of sense. T-wave represents that the ventricular repolarization, meaning it's starting to repolarize to get ready for the next contraction. Okay, thank you about that. There could also be a pathologic cue, like this one. I'll explain all these next week. They may not make sense. So this is what I mean by the zones. Okay, so this one, like I said, remember that your coronary arteries here, they branch out of the aorta. Okay. So when they only receive blood during the diastole, and then of course if you have any obstruction here, for instance, it's always the distal part that will suffer, correct? So this one here is the zone of ischemia, and then injury, and then of course the dead tissue is always in the distal part. They always start in the subendocardial layer, by the way, meaning this part right here. No, that's not it. This part right here. So this is your subendocardium layer. So it's not going to be on the actual endocardium, but the subendocardial layer here. So this is the part that actually suffers the necrosis, if we're talking about layers of the heart. We'll get to signs and symptoms and then the complications that result shortly. So at the time of the injury, the patient, can somebody read this please? Ms. Lachenpa.
Infarction is a dynamic process that does not occur instantly. Rather, it evolves over a period of several hours.
Okay, so you have time here, but regardless of how long the time, take note that time is tissue, just like we talked about in stroke. So the longer the patient's heart is deprived of oxygen, then the more tissue you lose. So it evolves over several hours, and then it continues over several days to several weeks after the initial injury. So the patient here, as a result, will have these problems here. So there'll be electrolyte imbalances which do not help with the injured heart. And of course, the decreased cardiac output that results here wouldn't help because it will trigger catecholamine release. Remember that when cardiac output drops, it will automatically trigger the release of epinephrine, norepinephrine, increasing vasoconstriction, which is going to increase your preload, your afterload, and then it will also affect the RAS system, renin-angiotensin system, which releases aldosterone, increasing preload, increasing blood volume, and then epinephrine also increases the heart rate. So all of these here do not help because they will increase the workload of the heart, increase the afterload, increase preload. So that's why this will explain the medications again that we will give shortly to a patient having any acute coronary syndrome, because we need to suppress the adrenergic responses. So we need to stop or suppress the catecholamine release because they won't help during acute coronary syndrome. Thank you for reading this part again, Miss Lamo.
Yes, Professor. Obvious physical changes do not occur in the heart until 6 hours after the infarction, when the infarcted region appears blue and swollen. These changes explain the need for intervention within the first 4 to 6 hours of symptom onset. After 48 hours, the infarcted area turns gray with yellow streaks as neutrophils invade the tissue and begin to remove the necrotic cells. But 8 to 10 days after the infarction, granulation tissue forms at the edges of the necrotic tissue. Over 2 to 3 month period, the necrotic tissue eventually develops into a shrunken, thin, firm scar. Scar tissue permanently changes the size and shape of the entire left ventricle, called the ventricular remodeling. Remodeling may decrease left ventricular function, cause heart failure, and increase morbidity and mortality. The scar tissue does not contract, nor does it contract electrically. Thus, this area is often the cause of chronic ventricular dysrhythmias surrounding the infarcted zone.
Okay, thank you. All right, so you have an idea here of what this patient will be facing after the MI. So the patient's problems is only beginning here. So after an MI, the patient will be expecting several more complications after the initial injury. So this will be similar to the secondary injuries we talked about in traumatic brain injury, wherein you had primary injury and then you had several secondary injuries. So let's begin with the few hours after the infarction. So remember, we're talking about an infarction here. Tissues die. So they won't form scar tissue until they heal. Now, I'm not saying here that the heart will heal as in like go back to normal here. No, because the dead tissue is dead. However, they will form scar just like when you injure enough, which this one is obviously deep. It will form scar tissue. Now take note that scar tissue do not function the same as normal tissue. It will never replace normal tissue. So let's start here with the changes. Now, this period here, because you have severe inflammation, and proof of that inflammation is your ESR, CRP will increase. And when these neutrophils here invade the tissue in order to, of course, their job is to, the dead tissues are now considered foreign because they're dead tissue, they no longer look like normal cells, so they will be attacked by your white blood cells and then eaten up. Okay, so that's their job, to remove the dead tissue. During this period wherein you have a lot of white blood cells. Now, if you remember in third semester, what was one of the causes of pericarditis in chapter 35?
Dental work?
That was endocarditis. For pericarditis, there were 4 mentioned in your textbook in chapter 35. What were 2 of those?
Lupus.
One was lupus, very good. Connective tissue disorder. What else? The other is infectious.
Rheumatoid arthritis?
No, not RA. So we have lupus, and then the other one was infectious. Could be like endocarditis. You have bacterial, fungal, viral infection. What were the other two? The other two causes of pericarditis?
Post-MI.
It was MI. Okay, so within 48 hours after an MI, this patient is at risk for pericarditis. This is caused by these white blood cells here invading the tissues because of course, the pericardium is attached to the myocardium, right? So therefore, the dead tissues, once there's inflammation there, it will inflame the pericardium as well. So the patient will develop pericarditis here right after an MI within 48 hours. In fact, this patient will likely suffer another pericarditis episode up to about 2 weeks later after the initial after the MI. So if it occurs within 48 hours, that condition, of course, is acute pericarditis. If it occurs later, about 2 weeks after, then that's already called Dressler syndrome, but it's basically still pericarditis. And about 2 weeks after, this patient is already in cardiac rehab. They're no longer in the hospital. So that patient now has a scar tissue formation. And remember, that scar tissue is not normal tissue. It cannot replace. They're just there. Okay, there's scar tissue to replace what was dead. And remember, that will weaken the heart, causing the heart to remodel. So the remaining healthy parts of the heart, the remaining functional parts, will have to, of course, compensate for the loss of their comrades. So there are now sections of the ventricles which are now all scar tissue, which do not contract. They cannot function whatsoever. So the remaining healthy functional cells will have to bear the burden of producing cardiac output here, causing the heart to change shape. The remodeling will depend on the parts of the heart that was killed, okay, that was replaced with scar tissue. Either way, though, it will enlarge the heart because that will involve increasing the size of certain parts of the ventricle in order to maintain cardiac output. All the rest here are very specific to the MI, so I'm not testing these. Okay, so the changes specific to the artery involved, I'm not testing you on that. So you can disregard that part. So let's start with prevention. So promoting health promotion and prevention, of course, is eliminating the risk factors. These are your risk factors, chart 38-1, smoking number 1, diet, high cholesterol, physical inactivity, and diabetes, hypertension, weight. So these are, again, nothing new. They look very familiar, right? You've seen this in chapter 36 as well, because these are exactly the same risk factors responsible for causing hypertension. And if you also remember in chapter 64 under diabetes, these were exactly the same things as well. Please read those on your own, especially the activity part. This one, how much exercise really is recommended. And as far as diet, so this would be, of course, your DASH diet would be included here, including sodium restriction. Do you see alcohol elimination here? I see stop smoking, but does it say stop alcohol? You read it anywhere?
No.
No. So alcohol may be continued as long as it's not excessive. Metabolic syndrome was also mentioned in hypertension, chapter 36, as well as in chapter 64, diabetes, making metabolic syndrome a risk factor for all three. So they share the same risk factors. Now, metabolic syndrome is not diabetes, it's not hypertension. So this one is somewhere in between. The characteristics of metabolic syndrome is, number one is the weight, the waist circumference. So the waist here is 40 inches or more in males, and I forgot what the waist circumference was for females. But anyway, metabolic syndrome is usually number one risk factor here is obesity. They do have a high A1C as well as a high systolic, or more like borderline systolic blood pressure. They're not quite at 140 systolic yet. Oh, it's right here. Duh. Okay, table 38-1. These are your characteristics of metabolic syndrome. So this is what I mean by it's not really hypertensive yet, but they are right there. So they have high cholesterol, and this is the circumference. So it is 35 for women, 40 for men. So you can say this is particularly abdominal obesity, okay, or central obesity, which is where I'm at. I think I have, well, not really. I'm almost at metabolic syndrome. For ethnicity, so this is patient-centered care. So there are certain demographics that are more affected, just like hypertension and diabetes. Please read that on your own. Besides age, we have different risk factors, but what makes women mortality higher than men is the characteristics of the MI. Most patients with MI in females do not have the typical chest pain symptoms. They have vague manifestations. Most women have non-STEMI rather than STEMI. And because they have atypical chest pain, or sometimes they may not have any chest pain at all, making heart disease the number one killer in women, or at least one of the top killers. Here's again another PCC for a certain age group in women. So premenopausal increases their risk. So as far as prevention, of course, you know the risk factors, so avoid or modify those risk factors. Let's go now to signs and symptoms. Now, on top of the chest pain, there are associated signs and symptoms. You will not see these associated signs and symptoms in chronic stable angina. In chronic stable angina, you only have chest pain. That's it. And the chest pain there is predictable. It's reproducible. The patient knows what triggers the pain. The patient knows what can eliminate the pain. Not so in acute coronary syndromes. So in unstable angina, non-STEMI, and STEMI, there is an accompanying or associated signs and symptoms on top of the chest pain. Some patients may not say chest pain, but they feel pressure. Regardless, please remember or be aware that you are supposed to assess the pain comprehensively. So you don't just stop with, well, how bad is it? That's just one component. Remember, the patient pain assessment must be a complete PQRST. So that will include what makes it worse, where's the location, what makes it better, how is it affecting ADLs, etc. When did it start? How long has it been? What does it feel like? Okay, so these are some. There will be a list comparing both. There will be a table shortly. And it's right here. The chart 38 is a chart. Chart 38-2. So if you compare between angina, particularly chronic stable angina, and an MI. So in angina, there are no associated symptoms, few if any. Whereas look at the patients with MI. On top of the pain, so the time here, of course, this one is lasting less than 15 minutes and is relieved by nitro or rest. This one, only opioids will relieve the pain. Duration is way longer, and look at this long list of associated symptoms here. Now, if you can either memorize this or just understand. Now, what did we say was going to trigger the what will be triggered here? Because once you have ischemia, myocardial ischemia, so this is now the start of the pain. Therefore, you know that the myocardium is not receiving blood flow, correct? So what's happening to the contractility here of the heart once there is ischemia?
Reduce.
Reduce. What happens to cardiac output?
Reduce.
And what happens when you have reduced cardiac output? What will be automatically triggered?
Catecholamine release.
Catecholamine release. So if you look at these signs and symptoms here, these are all related to fight or flight. These are all effects of your catecholamines. So there is now this is a combination of reduced cardiac output as well as catecholamine release. So there is increased heart rate, there's vasoconstriction, and we're talking about systemic here. Plus the patient, of course, has decreased cardiac output because of the ischemia or the MI, resulting in the rest of the symptoms. So here, obviously no cardiac output or not enough to supply the brain. So the patient has some disorientation, anxiety, dizziness. And then the rest here are combination of catecholamines effects as well as decreased cardiac output again. Here, like this one, for instance, so the skin doesn't receive enough blood flow, so it will activate your sweat glands. So patients typically present with these. So when they come into the ER, the patient at that point may or may not be fully oriented. Some of them may be confused. They'll become incontinent as well. So on top of this, you may be distracted by the incontinence. So some of them will have, they'll have bowel and bladder incontinence, which will make care a little bit hard, because now you have, especially, what's the usual profile of these patients again? From table 38-1, what do these patients look like? Are they skinny?
Obese.
Yeah, so these are, we're talking patients here, so they're heavy, and then they're incontinent, and then they have the cold and clammy skin. So imagine the picture here. It's easy to read on a textbook, but when you imagine the actual patient here, that will change your your outlook. So first, of course, there will be a team here. All right, and then care will also if, let's say, this patient called 911, so patient receives something from the paramedics before they reach the hospital. So you guys are familiar with MONA, right? The acronym MONA. Yeah. MONA, though, it's just the acronym. It's not complete. Plus, it's not necessarily in that order. In reality, it's more like ONAM, but who wants to say ONAM? So we say MONA. But the order really should be oxygen, nitro, and then they'll be given an aspirin and then morphine for the pain until we reach the hospital. Take note, there will be some temperature elevation. This is in response to the inflammation. Okay, when that MI occurs, when the necrosis occurs, it will systemically increase temperature. Please read the psychosocial on your own. The patient's responses here, of course, depends on the patient's stature or a status in the family, for instance. So let's say if this patient was a younger person versus somebody older or somebody in between, let's say they're the breadwinner versus someone who's past retirement, or let's say a younger person just going into college. So imagine the the psychosocial effects on the patient really depends on their where are they in life. Okay, so based on your Erickson needs, okay, the conflicts, right? So that will depend on who is this patient. I already mentioned troponins T and I, as well as the CKMB. Oh, you are being referred back to chapter 33. This is where they talked about this in detail. But however, please remember that we're testing 3 here because these are the 3 most commonly drawn labs specific to the MI. Troponins, TNI, and then of course your CKMB. Imaging, these are expensive, especially your thallium and your MUGA scans. I typically don't test these. I'm just testing you with the laboratory, right? Because usually in the acute episode, we don't, we have no time to get these tests done. An X-ray maybe, just to see if this patient is going into heart failure, because we need to see pulmonary edema, because that will require separate interventions. Like I said earlier, initially when they come in, it's hard to tell, what is this? Is this unstable angina? Is this non-STEMI? Is this STEMI? So we need, after you do your initial, the oxygen, you give nitro, and while all that is all that is being given to the patient, somebody is putting ECGs on the patient. So the minimum required is a 12-lead EKG. We have several types now. We have 18, 36 lead EKGs, but the minimum in order to make a diagnosis is a 12-lead EKG. In advance of next week, a 12-lead EKG gives you a 12 different views of the heart. Imagine the 12-lead EKG as a series of 12 photographs taken at different vantage points. So you have, imagine you put your heart on a table, then you have paparazzi taking a picture of the heart from different angles. One from the left, right, one from the bottom, one from the top, and then 6 of them around the anterior and the posterior sides of the heart. So that's the best description I can give for a 12-lead EKG. The doctor needs to see where are the ST wave changes occurring from. Is it on the left side, on the right side, on the bottom, on the top, or is it from the back? So that helps speed up the diagnosis, so that if this patient ends up in the cath lab, the doctor knows exactly where to put the catheter and deploy the stent. Okay. Of course, it will help with the CAT scan, CT angio, sorry, that they will be doing during the once this patient is taken to the cath lab. But initial diagnosis is crucial, and it can only be accomplished with a 12-lead EKG. So a cardiac monitor, therefore, doesn't give you that data. So typical telemetry monitor only gives you 3 to 5 views. So that's not a complete 12 view of the heart. And as already mentioned here, ECG must be completed within 10 minutes. Don't worry again, you're not the only one doing this. Okay, it's a team. So you're just one of many attending to this patient. We'll discuss the changes in chapter 34.
Professor, is this similar to the one that like they put on the patients to take home to monitor?
Oh, the Holter?
Yes.
A Holter is, that's discussed in chapter 34. A Holter is, especially if the patient, upon arrival to either the ER or the doctor's office, doesn't exhibit the dysrhythmia. So we can't keep them in there until we see it. So we'll send them home on a Holter to see them at home. And then most of these Holters have Wi-Fi capability. So they will transmit the data wirelessly automatically to the doctor's office. Or some central monitoring system. It can also be monitored by a certain company. Regardless, the Holter allows you to make a diagnosis because the patient wears it 24 hours. So whenever the dysrhythmia occurs, and then we'll also ask the patient, what were you doing at this particular time when it occurred? Okay, what were you doing? Were you eating, or what were you doing? Okay, what were you eating, or whatever? Okay, so we're trying to see when did that thing occur? What was the patient doing? So that the patient, the doctor can make a diagnosis. Again, a Holter is usually given if the patient, upon arrival, doesn't exhibit any of the symptoms. You know, you've seen that before. You went to your doctor, you complained of something, and then just when you arrive at the doctor, it's not there, right? Just like my car, for instance, something's wrong with my car, and when I get it to the mechanic, it's gone, right? Sometimes that happens. So in that particular example, and then the doctor suspects that it's a certain type of dysrhythmia, so he'll send you home with a Holter. Did I answer your question?
Yes, Professor, thank you.
All right. The exercise tolerance tests, these are not during the if the patient already has the acute symptoms, okay. But once the doctor already rules out or makes a diagnosis, for instance, let's say it's not non-STEMI, it's not STEMI, it's unstable angina. So with unstable angina, the doctor can do a exercise tolerance test or simply a stress test. Not so with the NSTEMI and STEMI, which go to the cath lab. Okay, but if it's an unstable angina, based on the ECG changes, then the doctor can do a stress test to determine the next plan of care. Of course, our best preferred gold standard for treatment here is, of course, cardiac catheterization. So we need vascular intervention to reperfuse the patient. However, not all hospitals have a cath lab. So let's say you're up in the mountains of Colorado somewhere, or maybe up in West Virginia, for instance, in a rural area. So the hospitals that they take you to may not have a cardiac intervention lab, no cath lab. So your best bet would be a thrombolytic. So just like what they gave you for stroke, so you'll be given a thrombolytic. So we can do PCI. PCI is, of course, the stenting, or you can do just angioplasty. Angioplasty meaning repair or vessel intervention, wherein they'll just use a balloon to open the catheter, the artery. Or PCI, of course, is opening the artery plus deploying a stent. Or if you're not a candidate, meaning you have 3 or more vessels involved, then you'll undergo bypass, coronary artery bypass. All right, pain is managed with morphine. Morphine here has two advantages. We have decreasing oxygen demand as well as relaxing the patient. And by decreasing oxygen demand, that means it will increase blood flow to the coronary arteries. A patient is also at risk for dysrhythmias. Again, dysrhythmias will be discussed next week. At the beginning of the MI, most common dysrhythmias you'll have are PVCs or atrial fibrillation as well. Because whenever you have a heart attack, remember that what happens to cardiac output when you have a heart attack?
Decrease.
Yeah, why does it decrease? Why does cardiac output, why does blood pressure drop during an MI? What happens to the heart?
Are the contractions weak?
Very good. So the contractions are not very effective. It's weakened, just like you. You got punched, for instance. You got sucker punched. So you're injured. You cannot do your job. So the heart here is ineffective as a pump. As a result, blood pools inside it. That increases pressure within there and can cause PVCs or even atrial fibrillation. 38-3 is your emergency care. So this is pretty much chest pain, any chest pain, or at least cardiac related chest pain. So ABC, then put the ECG leads on and assess the pain, vital signs. Those are your 4 basic actions first. So ABC, put on ECG, assess vital signs, and assess chest pain. Next, provide vascular access. You need one. If the patient came in by ambulance, we assume there's already one. This is already mentioned earlier, within 10 minutes, ECG. And these are your initial drug therapy. Aspirin. Aspirin has a long effect. So unlike nitro, which is gone in a couple minutes, aspirin, the antithrombic effect of aspirin can last up to 3 days. Longer, depending on your dose. Here's oxygen. And with any anxious patients, so you never leave these patients. We talked about this in respiratory therapy last week. The education for nitro, there's a, because nitro will be prescribed to this patient at home, regardless if it's chronic stable angina or acute coronary syndrome. So the patient will have nitro at home because they are at risk for another MI in the future. And we can't really eliminate the risk factors overnight or right after discharge. So this will be a lifelong lifestyle modification here to eliminate or decrease the risk factors. All right, drug therapy, I mentioned ONAM. So here is your, we give oxygen and then nitro, then regular aspirin. When we give nitro, how do we give this? Sublingual nitro?
You get every 5 minutes.
Okay, so it is given under the tongue, right?
Yeah.
Okay, so it's not oral. Is oral and sublingual the same?
No, oral is something you swallow, and sublingual is under the tongue.
Okay, so which one will have the first pass effect?
Oral.
Or does sublingual undergo first pass effect?
No, because it goes to the blood.
Okay, just want to make sure we understand that. So oral, of course, is in the GI tract. Now sublingual, although administered in the mouth, is not swallowed. All right? It is absorbed under the tongue. Here's a drug alert. This is for Viagra and Cialis. You've seen the commercials. Okay, don't take Viagra for chest pain. If you take nitrates for chest pain, as it may cause an unsafe drop in blood pressure. So this is the drug class for your Viagra. And what are you on, Michael?
Currently I'm not on anything.
Are you sure?
Yeah, hopefully never.
Okay. Here's a remember the patient in a MI or any acute coronary syndrome. There is catecholamine release, right? So we have epinephrine or epinephrine here. So will it cause moisture or drying of the mucous membrane? Because remember, there's vasoconstriction here.
Drying?
So, yeah,
Drying.
the mouth usually will be dry. So how can the nitroglycerin tablet dissolve is that if the mouth is dry? Can it? It can't.
It can dry.
No. So you have to moisten the mouth first. So you can give the patient 5 ml. So that's just a teaspoon of water just to moisten the mouth. But remember, this 5 ml is not used to swallow the tablet. Okay, this is just to moisten the mouth so it will dissolve the tablet under the tongue. Because otherwise, 5 minutes later, when you ask the patient to put in the next dose, the tablet is still there. It never dissolved. Okay, so consider that when you have the patient open the mouth, and you can see, I mean, you can tell if the mouth is dry. Okay, we get that white stuff at the corner of the mouth, you know, and then you can easily see the mucous membrane also if it's dry, pale. Okay, so consider putting a teaspoon of liquid there. Please look at these details here. I have at least 2 questions on this drug alert right here. Please read every word, every phrase, okay? So that paragraph right there, like these, for instance, these warnings like this, because that's all teaching. And then this one here, because that's your job with administering nitro. So you'll be giving this quite frequently in patients. All right. Now remember, this is acute coronary syndrome. What responds to nitro? Is it acute coronary syndrome?
Yes.
What did we read earlier? Remember, there was a difference between angina and MI.
Mm-hmm.
What was one of the differences? Does MI respond to nitro?
No.
No. Yeah, this is only, the chest pain here is only relieved by opioids, okay, not nitro. We have nitro spray now, which is better than the tablet because at least you don't need to moisten the mouth. So nitro can be tablet, sublingual tablet, or a spray. These are the positions, so it must be upright, etc. So here, again, a reminder, angina. When we say angina, we're talking about chronic stable angina. It responds to nitro. If after, especially after 3, is it angina?
No, it's an MI at that point.
No. Okay, very good. So here's a rescue. A reminder, please read that again. Now, once inpatient, or let's say the chest pain started inpatient, so you're in the hospital, patient complains of chest pain, you did the protocol, chest pain protocol, you used nitro. Now, if the patient doesn't respond to the first nitro, is it angina?
It could be.
Let me go back to this part here, 775.
In here.
Right here. Although this one is at home. Read this for me, Mr. Kimmins.
Professor, please, what page is this?
This is chart 3811, page 791. Please read this part.
It says place 1 nitroglycerin tablet or spray under your tongue, allowing the tablet to dissolve. Wait 5 minutes for relief. If no relief results, call 911 for transportation to a healthcare facility.
Okay, and then while waiting
for emergency medical services, repeat the nitroglycerin and wait 5 more minutes.
Okay, so will there be a difference here? This is at home and then versus in the hospital. Is it different? Of course, there's no, we're already in the hospital, so we don't have to call 911, right? But here, obviously, after you put 1 nitro, is this angina if there is no relief?
No.
No. But however, you still have to complete the protocol because that's the protocol, whether at home or in the hospital. However, once completed, do you repeat the protocol? You start from another, after you completed 3, you start another sublingual nitro protocol?
No.
No, what's the use? You already know.
We already know there's no.
No, it's not angina, right? So remember that, okay? Okay, we did that. Okay.
Professor, that was 3 nitroglycerin max, and then that's it.
Yeah. Okay, so let's say you completed the 3 nitro, and then the ischemia persists, chest pain persists. The doctor will now give you IV nitroglycerin. Please review your 103 on solving calculation for micrograms per minute, okay, because this is how nitro will be given. Did we do this practice before? Seems familiar. We did, right? No, this is a different class. Okay, never mind. So let's say your order is start nitro at start nitro, IV nitro at let's say 45 micrograms per minute, and then the pharmacist sends you a bag labeled nitroglycerin 250 milligrams in let's say 25 milligrams in 250 ml of NS. Do you know how to calculate that? That was in 103. No, micrograms per minute.
Yeah.
For those of you who haven't, who don't remember, please review that, okay? Because there will be at least one of those questions. And then the other question, math question, will be the titration part, because the initial order will say nitroglycerin 45 micrograms per minute. And then the titration will say increase nitro by 5 micrograms per minute every 3 to 5 minutes to control chest pain. So now you have an initial, you're running the initial dose, and then you're going to titrate it. Because if it doesn't relieve the pain, you have to increase the dose every 3 to 5 minutes. So this is what we're talking about here. So that's the titration for your nitro. So you begin at usual is around 45 micrograms per minute. And then you check your blood pressure, and then pain level will be checked every 3 to 5 minutes. It is increased at that interval. At every 3 to 5 minutes, the dose is increased until the pain is relieved, or you stop if the BP falls excessively, or if you reach the maximum dose. Medications are the following. So you have nitrates. Please read about this again. The ones that Michael is taking. Beta blockers. As you can see here, we have no calcium channel blockers. Okay, calcium channel blockers are contraindicated during an acute MI. All right, so you won't see calcium channel blockers here. We have, for acute coronary symptoms, these are your standard medications. So nitro, we begin with the sublingual or spray. No relief, you switch to continuous infusion. Beta blockers, and then your aspirin. All right. It's a drug chart, so questions will be on the nursing responsibilities and side effects.
Professor,
Yes.
what is the maximum dose for nitroglycerin?
The usual dose is 0.4 milligrams. You mean
Maximum
IV or sublingual?
sublingual.
Oh, sublingual, it's 0.4 milligrams per dose. So times 3, it would be about 12, 0.12.
Thank you.
All right, here's your morphine. And because we administer this thing frequently, we may end up, plus in a stressful scenario, we may panic, giving the patient too much. So look at your, make sure you have your Narcan. Oxygen, this is a given. This is the first thing we gave. Right now, the gold standard for vascular intervention is within 60 to 90 minutes. You've probably seen the commercials on the billboards for each hospital. They advertise these. They keep competing against each other as to who can get the patient in the cath lab and inflate the balloon the fastest. So the gold standard is 60 to 90 minutes. The sooner, the less time, of course, the better the outcome. So it has to be given within 4 to 6 hours, so similar to stroke. We already talked about aspirin. All right, so similar to stroke, patient will, this is already for after the acute episode. Okay, when we discharge this patient, they'll be on aspirin and or Plavix, just like stroke. If the patient has heart failure or develops a fib after the MI, in addition to that, of course, will be anticoagulants. We'll discuss that when we talk about AFib next week. I already checked beta blockers. These are the problems associated with beta blockers. So that's a select all apply question right there. And the patient is at risk for shock here, for cardiogenic shock, which we'll talk about in week 12. So we can skip this part here. This one is part of the complications, which is heart failure and cardiogenic shock. Here's a drug alert for your beta blockers, because these patients will be given a lot of beta blockers IV. That'll be metoprolol, 25 milligrams each dose, usually every 8, and then gradually we'll switch to every 12 hours. And if the patient does develop heart failure, and also to maintain the suppression of the catecholamines, we give the other drugs. We have ACE inhibitors or ARBs. This part here is only for patients. Thank you for reading this, please. For our calcium channel blockers, Miss Genus. Or not.
For patients with angina, the healthcare provider may prescribe calcium channel blockers to promote vasodilation and myocardial perfusion. These drugs are indicated for patients with variant angina or for those who have hypertensive and continue to have angina despite therapy with beta blockers, unstable angina. They are not indicated after an acute MI unless beta blockade is contraindicated. Monitor the patient for hypotension and peripheral edema and review the frequency for angina episodes.
Okay, that's clear, right? Please, again, a reminder is they're not used after an acute MI. This is the only exception. If the patient has any contraindication of a beta blocker, such as, for instance, asthma or any other risk for bronchoconstriction, then that's the only time we may use calcium channel blockers. Statin, of course, that's for long-term therapy to decrease your risk for atherosclerosis. Let's go now to vascular interventions. Then we'll give you a short break in 2 minutes. This one will be fast. I mentioned earlier, if the patient gets to a hospital with no cardiovascular intervention lab, then they'll only receive thrombolytic therapy. There are contraindications here, table 38.2. Did we test this in stroke? No, I don't believe so. So here are your contraindications. There are absolute and there are relative. Absolute meaning under no circumstance will the patient receive thrombolytic therapy. You already understand what alteplase will do. So these ones, no. If the patient has any of these, they cannot receive alteplase. If the patient has these, maybe doctor makes the call whether or not it's beneficial or if the risk is low enough. Okay, so the doctor has the burden of making that decision. And as with chapter 45, after alteplase administration, you have the best practice, right, with administration. So here it is again. If the patient's clot was resolved, there are indicators. So these are your signs. Okay, so that means the clot was dissolved. There is a this one is suspected ventricular dysrhythmia, specifically PVCs. Although other more serious ones may develop, but usually PVCs occur after reperfusion. Because remember, it does not eliminate the fact that the heart muscle did suffer injury. So there will be some irritability there causing dysrhythmias. The patient may also be on heparin infusion on top of these. So this is, of course, if the patient received thrombolytic therapy, then the heparin won't be given until 24 hours. You know that after from chapter 45. If the patient, though, receives cardiac cath, PCI. So they went to the cath lab, we got the balloon in, or we put the stent in. The patient will still be started on heparin. Okay, this is to prevent another clot from forming. For any surgical intervention, whether it's vascular or open heart surgery, pre and post-op will be the same. I'm not asking about cardiac rehab. I have no questions on cardiac rehab, so you can skip this part here. This one is specifically for the adult. I think this is already redundant. I don't recall having questions on chart 38-5 because the information is not something we haven't already discussed. And this is for the psychosocial, which again, I don't remember having questions on the psychosocial. Dysrhythmias we can skip because we will do this extensively in chapter 34. And heart failure, we already did this in chapter 35, at least you guys did in semester 3, so I'm not repeating this. And you also discuss hemodynamic monitoring, right, in chapter 35, although it was covered in chapter 35 for heart failure, but it's discussed here. Do you need me to discuss hemodynamic monitoring again? Yes or no?
Yes, please.
All right, so a quick rundown. Hemodynamic monitoring is for really sick patients, like patients who have an MI, they may be, during their stay in the ICU, they will be given a pulmonary artery catheter. Now it's threaded through the internal jugular, and then it will be inserted into the heart, and it will stop at the pulmonary artery. That's why it's called a pulmonary artery catheter. The catheter will have about 6 lumens. You see the whiteboard?
Yes.
Yeah.
All right, so let's say this is your heart. This is the right atrium, right ventricle, left atrium, left ventricle. So the pulmonary artery catheter, okay, this is the patient's neck somewhere here. Okay. Okay, so this is the heart. So it will have 6 lumen. 1, 2, 3, 4, 5, 6. Okay. Okay, so this is a catheter. So the one, again, this is the right atrium, right ventricle. So this would be the pulmonary artery. And then it will stop right here before it branches to the left and right pulmonary artery. So it will be right here. So there's a sensor here, there's a hole here, there's a hole here, and a few other openings as well, because there's total of 6. One is the balloon. The balloon is right about here, but we will deflate the balloon. We only need the balloon during insertion. So one of them is the balloon. This one's the right AP, right atrial pressure. This one is your PAWP. This is your pulmonary artery pressure. And I forgot what the other 3 are. One of them is for medication administration, etc. Anyway, they're color coded. So since these things have holes exiting at different parts of the catheter, so this one is again the balloon. This one will be, and this one will be connected to a transducer. Transducer. So this one will measure the pressure inside the heart. Obviously, since this hole here is on the right side, so this is your septum right here, So this is on the right side. So this guy here will be measuring right side heart pressure, whereas this one here, this hole here is measuring left side. Although it's not technically in the left atrium or the left ventricle, this is only in the pulmonary artery. However, anything that happens in the pulmonary artery is a direct, no, not direct, an indirect representation of what's happening on the left side of the heart. Because remember, your lungs here. So this patient, let's say, has left ventricular MI. Okay, so left anterior descending MI. So the left side is injured. So if the left side fails, and then of course there will be pulmonary congestion, will that be reflected on the pulmonary artery? Yes or no?
Yes.
Yes. So whatever pressure is registered in the lungs, in the pulmonary circulation, will be reflected on the pulmonary artery. So therefore, your PAWP is an indirect measure of the left side. So basically, long story short, the right atrial pressure or the central venous pressure is measuring the right side, whereas your PAWP or PAOP is measuring pressure on the left side of the heart, however, indirectly. So these are your numbers. What we'll use for the tests are the ones I highlighted. Right atrial pressure is between 2 to 6. Take note that there is no zero pressure. So some books will say 1 to 6. Regardless, it's about 6 maximum. Whereas the left side is about between 4 and 12 millimeters of mercury. Now, how is this asked? Now, depending on the reading, for instance, if I have a right ventricular MI, what will you see on my right atrial pressure? What pressures will be registered then if I have a right ventricular MI?
2 to 6.
So it'll be normal? I just had a right ventricular MI. So my reading will be normal. That's what you're saying.
Yes. If it's 2 to 6, right?
No, my question is, if I have a right ventricular MI, what will you see in the right atrial pressure?
Oh, it's not normal.
Yeah, so give me a number.
Number? More than 6?
All right. Whereas, as example here, so it tells you here, increased right atrial pressure may occur with right ventricular failure, whereas, when will you see it low?
So that means it's less than.
You gave me Lasix, right, to decrease preload. If you gave me too much Lasix, what will happen to my blood volume?
Decrease.
Will that be reflected in the RAP?
Yes.
Okay. And then same thing for the left. So if I have left side heart failure, what will you expect this number to be?
Number to be less than 12.
Less than 12?
No, less than 4, I think, right? It is a failure.
4? What does it say here on the next paragraph?
Measurement may indicate level or elevated.
Okay.
So more than 12.
All right, is that clear? Any question on right atrial pressure and pulmonary artery wedge pressure?
Yes, clear.
Go ahead. Did you say yes? There's a question or no?
So, Professor,
Yeah, they're basically just the one I illustrated to you. They're basically the pulmonary artery catheter is used to monitor pressure inside the heart. So the benefit of this is, rather than waiting for the patient to show symptoms, wouldn't it be nice if you see the events occurring before the patient shows symptoms? You want it before, or do you want to wait for crackles? You want to wait for a patient to go into heart failure before you know?
so it's before is better.
Yeah, so this one will tell you what's going on inside the heart before it leads to the point that the patient has symptoms now. So as the patient's heart is failing in real time, you see it happening with the use of a pulmonary artery catheter. So it gives you advance notice what's happening inside the patient's heart. So this is long before there is now congestion, and now therefore there will be pulmonary edema, which is much harder to eliminate and treat. So which one would be better?
Better to know in advance.
Okay, so that's the purpose of a pulmonary artery catheter. I won't do any of the care for it though, because that's advanced nursing care. But plus, it's basically like a central line. It's an invasive line. However, it's typically not. You could use it for medication administration, but we'd rather not. I assume you guys already talked about classification of heart failure using the New York or KILIP classification, classes 1, 2, 3, and 4. That's in chapter 35. I won't discuss it again. I may test it though.
Which one? D.
Classification of heart failure.
Oh,
Cardiogenic shock, I'll test on the final exam. We'll come back to chapter 38 when we get to shock, chapter 37. This drug is already regarding, this chart here is for treating shock, cardiogenic shock. So I'll skip that for now. I'll come back to that in chapter 37. I'm not testing the other interventions, so we'll skip this part here. This is now IABP. Okay, we'll resume here. So this is your pre and post care for a patient receiving cardiac catheterization. Again, it's the standard, the gold standard is 60 to 90 minutes of the onset of symptoms. It's nice to know the procedure, so please read the procedure on its own. So long story short, this basically is introducing a catheter with a balloon at the tip. So if it's only to flatten the plaque, to restore perfusion, this is called angioplasty. If you leave a stent, then that is now PCI, that's percutaneous coronary intervention. The patient will receive this drug, which is a direct thrombin inhibitor, bivalirudin, Angiomax. If you remember, this was also used in heparin-induced thrombocytopenia from last semester. All right, so let's do this one, and we're almost done. You need a break, or we'll just continue?
continue and finish.
All right, so we're almost done. So if we have a patient who could not have the cardiac cath, number one contraindication there is if there's a 3-vessel disease, for instance, then the patient will have to undergo bypass graft. It's not worth it to do cardiac cath because it's going to be useless anyway. So the patient will need bypass grafting. The most commonly used is the internal mammary artery. It's an artery, and plus you don't have to take it out somewhere and put it somewhere. So this one is already a branch out of the aorta. So this artery branches from the aortic arc and supplies your breast. So there's only one thing to do. Take it out of the breast, put it into the coronary vessel. As simple as that. So it's quicker to use, safer, less bloody, it lasts longer. Plus, again, it's an artery, so it resembles your coronary artery. So this is a perfect one to use. However, if the patients don't have that, then of course we'll have to get the vessel from a vein. Okay, that's your saphenous or your popliteal, any other leg vein. So it has to be harvested from your leg. So on top of your chest incisions, the patient will also have at least 2 incisions on the leg. These are your indications why we would do open heart surgery or bypass graft versus the cardiac lab. These are your indications. So that's a good select all apply question there. Pre-op care, the patient will have extensive showers with 4% chlorhexidine. So this is Hibiclens. This is a antiseptic soap. Most cardiologists will require 2 showers, one the night before, one the day of. Whereas some are also just happy with 1 shower, but most of them require 2. This is your pre-op teaching. As you can see, as with any other pre-op patient, you start your post-op teaching in the pre-op. It's just more extra. It's extra scary because the patient will have a big, long sternal incision. So it's important to reassure the patient that there will be analgesics. You know, they'll have PCA afterwards. They will, however, do early ambulation. So cardiac rehab will begin after 24 hours. Now the incisions, like as I mentioned earlier, besides the sternal incision, if the patient gets vessels, if the graft that we're using, the blood vessels that we're using is from the leg, the patient will have at least 2 leg incisions. There's 2 because they get the vein endoscopically. So they will have to cut one from the upper leg incision, usually in the behind the knee, and then the other one will be above the ankle. So let's say that's the vein they're harvesting. So there will be 2 incisions, one to cut it above, and then of course to harvest it from the lower leg. And then they'll take it out. Before they had a long incision, before they had the endoscopic procedures wherein they can just have smaller 1 to 2 inch incisions to harvest the leg. Before it was like a really long leg incision, wherein they cut the skin open and then literally take the vein out that way. Now they can do endoscopic, shorter leg incisions. Because you crack the chest open, there will be a lot of drainage, a lot of bleeding. So the patient will have chest tubes, either 1, 2, or 3. chest tubes to drain fluid so that the patient doesn't develop cardiac tamponade post-op. And there will be Foley because they'll be restricted from getting out of bed during the first 12 to 48 to 24 hours. Then they'll have pacemaker wires. This is part of the, when they put you in the temporarily on the heart-lung machine, because remember when we do open heart, we have to divert your circulation to an artificial heart, pretty much, a heart-lung machine. And they do the bypass, and then when they restart your heart, when they restore circulation back, they need to give you a pacemaker, a temporary external pacemaker. And of course, we monitor you with the pulmonary artery catheter. Another name for the pulmonary artery catheter, in case you get it on any exam, is called the Swan-Ganz catheter. Swan, like swan, the bird, and Ganz is G-A-N-Z. This is nice to know, but I encourage you to read. That way you're familiar with what they do for any open heart surgery. So when they do the bypass, again, they have to stop the heart. So they divert your circulation to the heart-lung machine, because the heart here is not working. Because would it be safe to have this heart beating while you do the bypass incisions? When you put the grafts and attach it here, can you do that with this heart beating constantly?
No.
No. So you need to stop it. Okay, here are the picture of your grafts. So you can have several grafts. So these are your vein grafts, and this is your internal mammary artery. So as you can see, it's cleaner. Okay, so this is already attached to the aorta. So all you do is just take it out from the breast supply and then put it here. Okay, it's easier. Whereas this one, you'll have several incisions because these veins here came from the leg. So you have to attach it here, attach it here. So it's a lot more work. No questions here. I have some here. Okay, so this is part of your post-op. Electrolyte monitoring, and for post-op monitoring, including hypothermia and hypertension. Chest tubes, you already know how the chest tube works. It's the same chest drainage system. This one, the difference is this is not in the lung or not in the pleural cavity. This one is in the pericardium. It's in the pericardial sac. Please read this part here. This is your protocol. So if you have more than 500 ml, no, at least 500 ml, this will be retransfused to the patient. You're familiar with the Constavac, right? Yes or no?
With the what, I'm sorry?
A Constavac, it's a drainage system. It's sterile. It collects blood drainage from any incision, and then the blood stays sterile, and then they will transfuse it back to the patient. I mean, it's his own blood. Are you aware of that? They use it for knee surgeries sometimes, hip surgeries.
Is it similar to the cell salvage machine that they use?
Well, this is in a can. It's in a plastic sterile box. It's a drain, but then the blood is preserved. And then once we reach 500 ml, we will transfuse it back to the patient. It's basically a collection device. And then when you reach 500, we will transfuse it back to the patient. And no problem, because it's, again, it's their own blood. As long as the system stayed closed, meaning it wasn't disturbed, it wasn't open, so we assume the blood remains sterile. Again, these are remember cardiac tamponade in chapter 35? Yes or no?
Yes.
Okay, so after chest, one of the causes of cardiac tamponade is after open heart surgery. So the chest the chest tubes become blocked, it will result in blood accumulation in the mediastinum, cardiac tamponade results. So these are your Beck's triad, and then call the physician if you see them. I have no question on this. You can disregard that. Pain management will be PCA. They'll be on morphine. Okay. This part here is monitoring the source of the force. So for internal mammary artery, no problem, because it was from an artery. But this one, if it's from the leg, then you have to monitor those harvest sites as well. So check for circulation and perfusion of the distal part of that leg from where they got the vein or veins from. It may not involve only one leg, because it depends on what the status of the vein that they got is. If it's not good, then they'll do the other leg as well. So you may have several incisions. So 1, 2, 3 or more incisions will be seen on the leg. Okay, regardless, you monitor those for circulation. Although this is rare, you can have sternal incision infections, but again, they're rare because I mean, it's it's under sterile conditions. They typically don't staple it anymore. They just have the skin glue. They do because the important part that needs to be closed is really the sternum. So as long as the sternum is closed, then the chest incision is just glued together. It doesn't really require any staples or stitches. Okay, this is the pericarditis that I mentioned earlier. So this is from open heart surgery, the post-pericardiotomy syndrome. This is another cause of pericarditis. I have no questions on mid-cab. You can skip that. I mentioned already endovascular vessel harvesting. So this will be smaller leg incisions instead of long ones. This is the current techniques now. I have no question on these procedures of robotic surgery. Okay. All right, we're almost done. We're about to discharge this patient now. So one of your teachings is chart 38-9, because most of our patients having bypass surgery are elderly. This one is redundant. We already talked about decreasing risk factors, so stop smoking, moderate drinking, change diet. All right, for activity, this will also include sexual activity. So walking is the best exercise. This is the gradual progression. So from the hospital, they'll have 400 feet. So this is typically the hallway. Okay, so you just measure, you count the number of tiles on the floor. That's your 400 feet. So you count 200, they walk back and forth, that's 400. They will be taught to carry nitroglycerin always. So after an MI, they will be at risk for another one. No straining. Okay, so that means, will they be on stool softeners?
Yes.
Okay, this is your gradual increase until they can reach 3 to 4 miles. Okay, so that's for exercise. Here's sexual activity. Now, the suggestion is not really based on time. Some books say 4 to 6 weeks after surgery, but that's not the very good basis. It should be based on the patient's tolerance. If the patient can walk a block or climb 2 flights of stairs, then they can safely resume sexual activity. That's the better basis rather than time, because we don't know how much the patient's progress is with activity. So if they can do that sooner, it's really based on activity tolerance. Of course, they cannot probably resume at the same level. Okay, there will be some modification. So they may not be the active participant. Okay, they may assume a more passive role during sexual activity. We already know about the Viagra and all that. Okay, so include that in your teaching. So these are the usual drugs we will discharge the patient with. These are standard. So when you work in a cardiac floor, open heart surgery, you'll have a discharge checklist, and it's literally a checklist. You check what the patient is going to be given. So part of your discharge paperwork is this one sheet of paper telling the patient what to take. So there will be aspirin and Plavix, that's what P2Y12 inhibitor is, beta blocker, a statin, and ACE inhibitor or ARB, or both. These are again standard. So the patient, if they don't have one of these, then it's your responsibility to tell the doctor. Okay, tell the doctor that, hey doctor, I don't see you ordering this, it's missing. You want me to add it, all right? So each patient must be discharged on that. This is part of your core measures for after an MI. You know this already, right? NSAIDs are contraindicated? Yes? This is on top of the kidney and the GI side effects of NSAIDs. Although this is quite new, this is probably in the last 7 years, because I didn't see this in the 8th edition of this textbook. I saw it on the 9th. Well, this is the 9th edition. So on the 8th, it wasn't there yet. This one wasn't included. So it's fairly new. Okay, because of nitro, I have questions on nitro, especially on teaching for a patient. So they cannot take it out of the bottle and keep it on another container. Okay, it must be kept in its original container, which is usually light resistant. It's colored dark brown. It should be replaced every 3 to 5 months. There should be a tingling sensation when used. It should not be swallowed. Okay. Again, this is your teaching. And that should be, oh, there's still one more here for, no, there's no beta blocker teaching, because that was covered in chapter 35. All right, so these are your teaching. I'd like to emphasize, when do they call 911 again? Is it after 3 or after 1?
After 1.
1.
Okay, clearly says here after 1. Okay, so call 911 if it does not improve after 5 minutes or 1 sublingual nitro. All right, so it's not 3. All right, of course it's different when we're in the hospital because there's no need to call, they're already in there. So we all we do is complete the 3 nitros, and then if there's no relief, then the doctor will change it to IV nitro. These ones, obviously, these are signs of heart failure already. Or if they, if they're having to use nitro more often now, gradually they're having to need it more often, then there's something wrong. And remember, these patients are on beta blockers and or calcium channel blockers. Those are 2 sisters that are the same. We did have it here on the discharge medications. Where was that in? What page was the discharge meds? The one with the statins. Oh, right here. All right, so it may include a calcium channel blocker. Again, calcium channel blocker is only contraindicated after the acute episode. So it will be, so 2 instances, either the patient has a contraindication for beta blocker if it's after an acute MI, or on discharge. So the acute episode is over, so the patient can now safely receive calcium channel blockers. And that's it. Any questions, guys?
So the professor thought it's a miss which chapter, everything from the